I'm Kim Goodspeed. I'm one of the child neurologists in Dallas. My specialty is in neurodevelopmental disabilities. Been working with Amber since about 2018 when they got their diagnosis, and leading the natural history study there. Since I'm the first talk today after Laura, but the first to kind of dive into some of the science, I thought I would start with a little bit of level setting that everybody else is going to dive into more detail, and then a little sneak peek at what we're starting to see emerge from our year one data out of the natural history study. So, basic take-home messages are it's becoming one of the leading causes of genetic epilepsy and autism, and what we're starting to see is that kids are kind of segregating into two buckets. There's kids that have quite a bit of developmental disability and quite a bit of seizure burden, and these other kids that seem a little more mild, but even mild doesn't mean easy life. So just understand that if I say mild, I understand there's still a lot of struggle in that daily life, but the struggles are different, and for lack of better terms, we've split them into mild and severe. Because of Amber and the community's endeavors, there's a lot of options for treatments that are in development and even in clinical trial, which is just incredible. But we're still lacking outcome measures and biomarkers, and so I'll propose a couple of ideas today, but it still needs a little bit of work. So just to level set, 1 in 6 kids has a developmental disability in the US. 1 in 44 has a diagnosis of autism, and 1 in 26 have epilepsy, or at least one seizure in their lifetime. And to put that in the context of kind of a general American classroom that has around 30 kids, that's 1 kid in every classroom with seizures, and that's probably 1 in every other classroom with autism. So incredibly common disabling disorders, and many of those kids will have a genetic etiology at their core. And this paper came out in 2020. I love this slide. I know Terry Jo uses this slide too. It's just a really nice paper that highlighted the top genes are the top genes are the top genes over and over and over again. And SLC6A1 is up there, even though I had never heard of it until Amber came to UT Southwestern and was like, hey, we have this disorder, can you work on it? Then the whole point of trying to figure out these different genetic etiologies is try to understand what's happening in the patients. And I love this slide that came out of a review paper in 2016, but it gives you such a nice snapshot of what everybody in this room does and touches different pieces of this pie. So I tend to live in this green box where I'm working with the patients and I'm working on trying to figure out what tests can we do for patients to figure out what's working, what's not working, are there structural changes in imaging, are there EEG changes on their brainwave testing, are there any clinical features that we can pull out from histories and y'all's stories that we can then apply like a standardized questionnaire to give it a number. So that's what we're trying to fill in that puzzle piece while everybody else is working on the other stuff. So we've got our mouse and monkey and rat people. Then we've got our people in the lab doing the cell cultures and running things through and testing hundreds of mutations at one time, and then trying to figure out, do any of these drugs work? Is gene therapy going to be an option? And so all the while, this is all happening in this really incredible orchestrated dance that Amber and the foundation basically somehow puppeteer and master. So the whole point of this is so that you can get to clinical trial, right? We want to do all of these things so that we can understand it to the best of our ability and then have a successful clinical trial. How do you get a successful clinical trial is to be able to know what do we want to measure and how do we want to measure it. But even within a clinical trial, there's a ton of phases. So the preclinical phase, clearly ongoing, that's what happens in the lab with the cell cultures and the mice and all of the really incredible work that the wet labs are doing. In a traditional drug study, a phase 1 study is going to be in healthy participants. So healthy volunteers off the street have no medical problems. Is the drug safe? Clearly, nobody's signing up to get a gene therapy unless you have the disease. So phase 1 studies in gene therapy, at least, are probably not going to have healthy volunteers. We're going to start in our patient population. So we're kind of starting at that phase 2 place where you're looking at the patient population and checking to see, is it safe? Well, in rare disease, we also need to check on efficacy because we don't have that many patients. And we want to make sure that we do as much as we can with every step of the process. And so typically, a phase 3 study is when you would really focus on efficacy, but we end up kind of lumping all of that into one big study in an initial group of patients. There will probably need to be additional studies of efficacy in larger groups, but at least in that first study, we're trying to get as much as we can, which is why those of you in the Ravicti study, I'm not part of that study, but I bet you're going through a lot of blood draws and vital sign checks and lots of check-ins with Dr. Grinspan and Dr. Demarest to make sure that everything is safe, while you're also filling out the same questionnaires that you have filled out for every single registry that we've ever asked you to get into. And thank you is all I can say. I know it's redundant, but it's really appreciated, and we really do have to have all those data points in order to move things forward. So I know it's painful, but it's really appreciated. But even once a drug gets approved, you still have to continue to monitor, right? We need to make sure that it's still safe outside of that initial 1, 2, 3 years that you're in the intense part of the clinical trial. So you're gonna need to continue to follow up and check in, and maybe once a year be checking in with the study staff. So it's a long process, and we understand and we appreciate how much of a burden it can be, especially when you're juggling a million other things, but it's really, really appreciated, and it's so important. So how do these clinical trials get done? The gold standard in general is a placebo-controlled, double-blinded, randomized controlled trial. What does that mean? Take a whole group of patients, you randomly assign them to 2 groups. One group gets the experimental treatment, one group gets a placebo or sugar pill or the non-treatment, and you follow them over time, see who does better. Hopefully your experimental treatment does better, but that's what you look at the end. What is happening with the Ravicti study that they will talk about is you just don't have that placebo-controlled side. So you're just running through open label, everybody's getting drug, and we're seeing how it goes. But there's other ways to think about it that you guys may come across, so I just wanted to throw out these terms in case you encounter them over time. N of 1 clinical trial designs are becoming pretty popular and common in rare disease worlds. So N of 1 means you have 1 patient. So whenever we use the term N, that's the number of participants or the number of mice that were in the study. So N of 1 means 1 participant is in the study. Typically, you're gonna follow them for a period of time, see how they're doing, give them a treatment, stop that, let it wash out, see how they did, and then give them a placebo, and then keep going. And do that pattern a couple of times if you can, depending on the treatment. But the whole goal is that that individual serves as their own control. How they were at the beginning of the study gets compared to how they are at the end of the study, or at specified intervals along the study line. And so that's one way to reduce the number of patients that you need. And for certain treatments, it makes a lot of sense, especially in super tailored medicines that are really made for that one individual. But other things that I think can work are these randomized placebo phase trials or run-in studies or lead-in design studies. There's different ways to call them. Basically, you follow some patients. So maybe we have everybody in our natural history study, and then randomly patients get pulled out of the natural history study to be enrolled in a treatment trial. The other people that are doing the assessments in the study don't know when somebody's off natural history and on treatment, and so you have a little bit more rigor of people who are assessing the kids that don't know that they've been treated. They're blinded to that treatment. And then you follow them over time, and the presumption is that those who get treated earlier have their scores start to change faster. So I only put this all out there to say there's a number of ways to skin the cat, and we're trying to be as creative as possible. None of these are gonna be easy on families, though. They're all gonna require a lot of time, effort, time away from work, time away from your other kids, and lots and lots of questionnaires probably. So switching gears into SLC6A1, just to quickly lay the groundwork, and then others will dive into this deeper. It is a GABA transporter. It's responsible for bringing GABA from that synaptic cleft, so the space between 2 neurons where they talk to each other, brings it back into that first neuron that had been sending the signal out. The presumption is that there is a dysregulation of GABA homeostasis. So what does that mean? Basically, neurons are like Goldilocks. They want everything just right, in the right places, at the right time, and at the right levels. And without this transporter regulating that GABA, you lose that ability to control how much GABA is where and when. So the magic bullet is there too much or too little? I think it's probably both, which might be a blasphemous thing to say, but I think it's too much in some places, too little in other places, and that imbalance is just there. But we'll have more to come on that. So what have we tried to do from the clinical side? We started with a retrospective study that we started back in 2018, got it published, I think, in 2020. And then in 2020, we started our clinic because we were in the middle of the pandemic and telehealth was available across the United States, and it was great. And so we were getting to see kids from all over the country from the comfort of their own homes and getting to meet you, hear your stories, and learn about you. And then in 2021, we were able to open the actual natural history study where people were starting to come see me in Texas, which was lovely. Some of them got the burden of the heat, and some had the lovely weather in November when it's like a balmy 70 or 60 degrees. It was 80 last week. So it's been a lot of fun. We've met a ton of you. It's been really, really great to hear your stories. I really appreciate you taking the time to get on a plane with your children with disabilities. I know that's not an easy feat. And we've been doing an EEG study, so their kids are hooked up to an EEG for 4 hours, which is also quite painful and frustrating. So while mom gets to fill out or dad gets to fill out all of the forms that we make them fill out. So the whole point of this, though, is that we want to figure out in this group of patients what's working, what seems to be capturing their stories, and then hopefully continue with a bigger group. And then eventually roll that into a clinical trial where we say, we know what kids look like on these questionnaires, and we think this is how we're going to do better. So the literature review identified epilepsy, developmental delay, and autism were those core features. And what was interesting, I think, is that y'all all told us that they were having staring spells and eye fluttering, but that wasn't really represented in the literature as much because the myoclonic atonic seizures, or those sudden muscle jerks and drop attacks, were what really were coming out in the literature at that time. And so we were a paper that was able to push forward, like, it's really absence epilepsy seems to be the more common thing that patients are reporting. And then we partnered up with Simons and said, hey, your data looks like my data, when I happened to meet Jennifer Bain at the first SLC6A1 meeting in 2018. And we were like, yeah, that's really interesting. We should look at that. And so we pulled our data from the literature, and then we pulled her data from Simons and said, oh, look, it actually is pretty similar. And in most studies, you want a p-value or a significance level that shows that there's a big difference. But in this, we were wanting something that showed that there was no difference. And it was true. There was no difference in the rates of epilepsy, intellectual disability, or developmental delay, and autism reported in these two groups of patients. But when you use a standardized measure like Simons, which you'll get to hear about after my talk, you get to learn other cool stuff. So hypotonia, low muscle tone, as well as movement disorder or ataxia, so that tremor, shakiness, ataxia, balance, coordination problem, that was all getting picked up by the Simons data because parents are being asked a standardized questionnaire and are reporting, yeah, these are all the things we see in our kids. And so we got to learn even more cool stuff as opposed to the bias of people like me who think that autism is cool because I'm an autism doctor and I may not have reported that out in the literature that, you know, the patient also had ataxia. So it was a really nice paper that I hope has been well received. From there, we started our study where kids are getting a medical history, an exam, and then an EEG with us. And then we've just launched an MRS biomarker study. So we're doing MR spectroscopy, so a different type of MRI, to actually measure GABA levels in the occipital lobe, or the back region of the brain, and doing a few different questionnaires. So what have we seen? We have seen, again, kind of a milder phenotype and a more severe phenotype. So some kids that have intractable epilepsy are on multiple seizure drugs, and seizure drugs aren't working. And then other kids who seem to get relatively good seizure control off of one agent, maybe their second agent. But almost everybody presented within the first 6 months of life with low tone and motor delay. And then if they missed that window, they were picked up around their second birthday with their first seizure. And one thing that I think is kind of interesting with this disorder is it's incredibly heterogeneous in terms of the mutations or the variants that everybody has also. So we had all missense or nonsense variants. We didn't have any deletions or duplications in our cohort. And that's been pretty true across the board. And I think in our brain communications retrospective paper, there was almost 90 different variants identified in that paper. So it's a really heterogeneous group in terms of genetic variations, as opposed to some of these other genetic disorders that have a couple of core common variants that are found in the group. And then the other things that were striking is that the kids that we are now classifying in this severe group tended to meet their developmental milestones later than those who had or were classifying as the mild group. But pretty much everybody had some degree of developmental delay. And over half our group had epilepsy or seizures, or at least SLC6A1 spells, as Dr. Dimmerston and I have talked about, because the EEG does not always match what the clinical picture is showing us. And then the other thing that was just interesting was that the kids that had more severe disease also had a higher prevalence of autism. Again, this is preliminary data. This is a relatively small group. We need to continue to explore this, but it feels like these two different buckets, at least, probably more, could be identified, are emerging. And then the seizure phenotype. So what was really encouraging to me, I'm not an epileptologist, I don't read our EEGs, I'm partnering with Dr. Deepa Searcy at our center, who's reading them, and after she'd seen a couple, she's like, Kim, they have kind of a distinct pattern. We have this intermittent rhythmic delta that kind of stands out. So if you can look in the top right-hand corner, and you can notice these nice, pretty kind of 3 bumps between the 2 lines kind of pop out from that background. That's the intermittent rhythmic delta activity. Not that exciting, I guess, to see just in a picture, but we saw it in almost every child that we had. And then when I dove back through their clinical reports, if you looked in the body of the report, it was buried in there that they had some rhythmic delta in their background slowing. So this is what we want to chase after to see, is this a marker that we can quantify and maybe even develop a severity scale to say, like, give it a number again. Science likes numbers, so we're trying to convert everything that is story or picture into numbers. And then the other thing that I think is interesting, and this might be helpful for some parents if you're just starting on the seizure journey to be figuring out with your local physicians. So levetiracetam, or Keppra, is going to be the first-line agent that almost any kid with new onset seizure in the US is going to be prescribed. It's very, very common practice because it has very few side effects. You don't have to follow labs. It's a very convenient medication to take. It comes in a liquid or a pill, super easy. Except the one side effect that it has is a behavioral side effect. So I typically describe this to families, not necessarily SLC families, but families in general. This is like your toddler who has tantrums, but then all of a sudden they get on Keppra and they're getting kicked out of daycare for throwing a chair across the room. Like, it's not subtle behavioral changes, that they're just a little harder. And what was interesting, and I wrote it off at first, but it's truly, most of our kids with SLC6A1 in this study had that behavioral side effect with Keppra. And it was like, well, they had behavior issues before, and I don't know, and then they come off of it and like, oh, okay, it was the Keppra. And we did it enough times that I just have a healthy respect for these kids may not tolerate Keppra very well. There are a few that do. So it's not 100%, but it is one that I tend to avoid in this disorder now. For what that's worth, you can take it back to your people. So one of the questionnaires that I think I'm really glad we included was the Developmental Coordination Disorder Questionnaire. It comes in 2 flavors for 2 different age groups. I have lumped all of them together here, but it kind of changes by age. So what I'm depicting in blue, green, and yellow, these are the score ranges that are considered probable or likely to have a developmental coordination disorder. And pretty much everybody, except for one outlier, fell within those ranges for their age. And so this I find pretty promising. It's super simple. I think it was like maybe a 2-page, 20 questions or so questionnaire. Wasn't too painful for families to fill out. And I got a lot of feedback that it was like, yeah, these are the things that my kid can't do. And it was helpful. So this is one of those things that I think could be a number we could follow, and in a clinical trial that would be very easy. It's been used before, but it's not super commonly used. The other thing is the QI disability questionnaire. So this is a parent report measure that looks at how is the disease affecting the child from the parent's perspective. And the idea of this is that it's supposed to capture the disability of a disease in a patient who can't report for themselves. There's a lot of quality of life measures that are meant for the individual to say, how is it affecting me? But a lot of your kids can't tell you with that kind of detail. And it divides it into all these different domains. And the two domains that popped out as being the lowest scores, and low scores are bad, meaning more disability from the disease, were negative emotions and independence. And I think even just from Laura's talk this morning, and you'll see it peppered through the rest of the day, I think that's probably what drives a lot of the disability and the disarray in homes. So I'm hopeful this could also be a good measure. The kids are generally pretty healthy, so that physical health is relatively high. They tend to be pretty happy, outgoing kids, which also, those positive emotions are there, but I think the negative emotions are really impactful. So we'll see. And then this is the MR spectroscopy data. So thank you, Laura, for being the one patient who let JC come through, and this is his data. I'm sorry, I probably should have disclosed that, but I'm just so appreciative that you were willing to go with us on this journey. And we don't know if this is normal yet or not because I need a healthy control to compare it, but we did it. We had a kid with SLC6A1 who was under 10 years old in an MRI scanner without sedation. Like, huge round of applause for JC. Like, amazing. And so this gives me such great hope that we can push forward and keep trying to do this, because we don't know what GABA looks like in the human brain. We know what it looks like in certain mouse models and in cell culture, and we know uptake, but we haven't been able to look at it in the brain. And so I'm excited to see this. And so what we're looking at is this peak right here. My suspicion is that the peak is going to be lower than typically developing kids, but we'll see what we find. This is an example of what the data could look like. So one of my colleagues has done a similar study in a progressive myoclonic epilepsy, and they've been able to show a really significant difference between the two, GABA and glutamate, in patients with the epilepsy syndrome versus those with healthy controls, or typically developing controls. So hot off the presses, more to come. Hopefully by the time we meet again, I'll have some more data. And then the last thing I'm going to finish up with, and I am 5 minutes over, apologize, is we are launching a disease concept model, because as you guys know, your stories matter, but we need to turn your stories into outcome measures. And so I brought some of my team here with me today, and we'll be in the resource room to meet with you guys if you're interested, and we can give you some more information on what we're planning, and we'd love to get your feedback also on how we're structuring it. But Amber had worked with the trend community, and they did passive listening of your Facebook group to identify some of those key metrics or key parts of the disease that are really you guys are talking about. And so that's some of this data here. We have a publication hopefully coming out. It's under review. And from this, we want to build on it and move it into an actual formal disease concept model, which will help us when we go to the FDA with any of your disorders to say this is why we're measuring what we're measuring. And finally, I just love this Horton Here's a Who, because that's what this room is, right? Like, it started with Amber and Maxwell, and then, you know, enough people start gathering and the languages come together, the voices collect, and you get a room of really stellar people like this that are just amazing scientists, amazing experts in their fields, and it's like magic. So I will get off the stage now and let the next person come up, and I apologize I ate up some of your time.